Medicine must concern itself with both the soul and body of the patient. The ethical responsibility touches on who should, can, or will be saved, and medicine is not an exact science like mathematics or physics. For example, a 5-foot measurement remains 5 feet, whether it be in Dubai, Malmo, Alexandria, London, Santiago, Mexico City. All those who practice the healing profession sooner or later will be confronted with ethical dilemmas. And tonight, we have a distinguished professor from Vanderbilt University that will touch on some of the compelling conditions, their treatments, death, and dying.
Many patients experience depression, anger, guilt, and anxiety when diagnosed with a potentially fatal illness, particularly when it's cancer. A patient's state of mind can influence the way in which he or she responds to both diagnosis and treatment decisions. So it is critical that a physician be aware of a patient's emotions and not treat just the physical symptoms. Dr. John Altman is an oncologist at the University of Chicago School of Medicine. He's also a survivor of cancer and understands the emotional impact the disease can have on a patient.
I don't think cancer is any different than people dealing with advanced fatal tuberculosis or slowly dying patients with diabetes or heart disease. So the cancer has no special problems that are different in the sense of dying. The population has a terrible fear of cancer and associates it with a long, painful death. That makes it a little different.
Dr. Altman is currently treating Carol, a 50-year-old social worker who lives in a suburb south of Chicago. In January, she was diagnosed with large cell lymphoma, a cancer that originated with a tumor in her stomach. She reacted to that diagnosis the same way many cancer patients do.
I think at the very beginning, I was so frightened. I really didn't think I could face it at all. And I simply was clinging to the doctor's comments about their
Nashville. I am Michelle Garcia, your host. Tonight we will be discussing men's health, especially the draft recommendation by the United States Preventive Services Task Force and due for official release in October 2011. Tonight to discuss men's health, I have with me Dr. Arnold W. Malcolm, MD, MBA, FACR, Professor and Chairman of Radiation Oncology at Vanderbilt University Medical Center as our guest. Dr. Malcolm got his BS degree from Kent State University in Ohio in 1969 and his MD from Meharry Medical College in 1973. He completed his residency at Joint Center for Radiation Therapy, Harvard Medical School, where he became chief resident in 1978, while he was also a research fellow in radiobiology at Harvard School of Public Health, both in Boston, Massachusetts. Let's see. Dr. Malcolm, you are certainly highly qualified in this area of radiation oncology, and I am glad that we have you here today. Tell me, what is radiation oncology?
It's the study of cancers or neoplasms with treating with radiation, which is similar to getting x-rays as a chest x-ray. However, the energy of the x-ray beam is significantly higher than that, and the radiation basically disrupts the DNA or the mechanisms of the cancer, therefore killing them.
Okay, so it's kind of a concentrated beam. All right. Well, so it's a form of cancer treatment for patients.
Yes.
Okay. What stage, I mean, is this like the first course?
No, radiation oncology can be used alone. It can be used prior to surgery. It can be used after surgery. It can be used prior to chemotherapy or in combination with chemotherapy at the same time. So it can be utilized in many different ways at different times along the treatment for a patient for cancer.
Okay, so it can be used independently or
Yes.
concurrently with other therapies.
Correct.
Okay. Well, cancer, when people hear the term cancer, they think terminal. What happens when radiation cannot cure or mitigate the disease and suffering and the patient does pass?
I think the first thing I should say that when a person hears the word cancer, it does not mean, it's over. That's not true at all. There are hundreds and hundreds of types of cancers involving everything from the top of your head to the bottom of your feet.
Yeah.
So I think it really very much depends upon what type of cancer that individual may have. And then there's a broad category. With radiation oncology, also chemotherapy, the broad categories are palliative, that is, you're trying to help the patient in recognizing that they are not curable, but they have a symptom that you're trying to ameliorate so their quality of life is better. Then the other part, which we like to always think about, is curative or definitive. So we're using that treatment to totally eradicate the cancer.
That's awesome. Well, what are the ethical ramifications of this?
Well, the thing is, I think you have to be first very, very honest and straightforward with the patient in a kind way, explaining to them the intent of the therapy. And that's what the problem is. Sometimes patients don't want to hear, unfortunately, when you say, well, I cannot cure you of your disease, but I can make you feel better and I can make this pain go away in your bones. If you have bone pain, patients come in sometimes with very severe pressure on their spinal cords.
Right.
They can't urinate, they can't move their bowels, and the radiation can relieve that pressure, therefore that improve their quality of life. It's the communication which I think is the most important part.
Okay, so it's just being upfront with them. That's awesome, because I didn't know that, that you can use radiation to just kind of mitigate the symptoms, kind of minimize them.
Correct.
Let's see here. Are there new or recent advances in the treatment of cancer?
Multiple new advances, both from surgical avenues, chemotherapy and radiation. Just to give you some examples. Some of the new techniques in surgery are less invasive, and that they're done with robots and other things, and so the patient can tolerate the surgery better. Their recuperation time is markedly decreased. In regards to chemotherapy, we're looking at specifically targeting the action of the cancer cell that's causing it to grow. It's called targeted therapy, and so there's a lot of that investigation going on. Radiation oncology, there are new techniques increasing the long period of radiation from like 4 to 6 weeks down to a week. Making the fields actually smaller and being able to pinpoint what you want to treat, and therefore treating less normal tissue. So there's a lot of different things going on simultaneously.
Well, I'm impressed by that. I've known in the past people who have been undergoing radiation therapy and would have to go daily.
For the most part, it is a daily treatment. What people need to recognize that treatment only takes usually 10 to 15 minutes.
Okay.
Actually, the radiation beam was only on 2 or 3 minutes. The majority of time is setting up that patient accurately so that you can deliver that beam where you want to place it.
Okay.
There's no pain, nothing involved in it. You don't even know the beam is there. It's like getting a chest X-ray. You don't feel anything.
Right.
However, it is making a difference.
That's awesome. So it seems to me radiation oncology is difficult. I mean, sounds like it has to be precise.
Yes.
Detailed to the
Yes.
minimum, to the maximum. Tell me, Dr. Macklin, what's the difference between external radiation and seed implantation?
Okay. So external beam radiation means it's delivered through a machine that is maybe 100 centimeters away